Hi, everyone, and welcome to today's IJGC Journal Club. I first would like to thank all of you for attending the Journal Club, and I also want to thank ESGO and IGCS for their support of our IJGC Journal Club. Before we begin, I wanted to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recording will be made publicly available, and the participants with the cameras turned on may appear in the video recording. So we ask that everyone please keep your microphones muted so everyone can hear the presentation. If you're having any difficulties or questions, please send a message in the chat and our technical support team will assist you. Definitely we'll have time for questions and discussions, and we certainly encourage everyone to submit your questions via the chat platform through today's session. So with that, I wanted to welcome, of course, are the authors of this article, this month's lead article, which is titled Oral Contraceptive Use is Associated with a Reduction in the Physical Size of Fallopian Tube P53 Signatures by Ram Logan, Sawamber, and David Huntsman from the University of British Columbia in Vancouver, British Columbia, Canada. So I'm very, very pleased to welcome you. I want to thank you, of course, obviously, for submitting the article to our journal, accepting our invitation to be in the lead article, and of course, obviously, accepting our invitation to take part in this journal club. So I'll hand it over now to Ram Logan, and I think he's going to start with a short presentation highlighting all the details of this article.
Well, thanks, Pedro, for that wonderful introduction. I'm just gonna share my screen. Okay, so hopefully everyone can see that. So yes, so like Pedro mentioned, our paper is titled Oral Contraceptive Use is Associated with the
Ram
Reduction in the
Logan,
Physical
if you
Size.
wouldn't mind, I don't
Yeah.
think we can see the slides.
Okay, so let me. Okay, does that work?
Perfect.
Okay, perfect. Okay, so yeah, so it's oral contraceptive use is associated with a reduction in the physical size of the fallopian tube, P53 signatures. So I'm just going to provide a brief overview about the objectives of why we did the study. So we know that oral contraceptives reduce ovarian cancer risk, but the actual mechanism of risk reduction is not fully understood. So our primary objective for this study was primarily to examine whether oral contraceptive pills influence P53 signatures, which are essentially the putative early fallopian tube precursors for high-grade serous carcinomas. In order to approach this project, we initially started with a set of methods. So our clinical team here performed a retrospective cohort analysis looking at 250 subjects who were over the age of 50 years old and who had their fallopian tubes removed at the time of a benign gynecological procedure. So think about like a bilateral salpingectomy, so the removal of both the fallopian tubes. Within our cohort, we after sifting through a lot of the clinical data, we ended up having 72 patients who used OCPs for at least 5 years and 178 subjects who had no history of OCP use. Once we had assembled our cohort, we next moved on to performing immunohistochemical analyses. So we looked at P53 signatures, Ki-67, which is a marker of proliferation, as well as HNEs. And we had our pathology team review these samples for P53 signatures, which were identified and stratified based on size. Now, there are more results, but I wanted to highlight the main findings of this study. So when we ended up doing a Fisher's exact test of the patients within this cohort, we found that there were no significant differences in the number of P53 signatures between OCP users and non-users. But then we pivoted to looking at the size differences of p53 signatures between OCP users and non-users. And if you direct your attention to table 3, we found that there were um, significant differences in terms of the actual size of p53 signatures between OCP users and non-users, with OCP users having smaller p53 signatures. Yeah, so that was the main finding of our paper, and we found it quite interesting. So just going to conclude fairly quickly with what we had identified. We primarily identified that OCP exposure was associated with a shift towards smaller p53 lesion sizes, but was actually not found to be associated with a difference in the number of p53 lesions between OCPs exposed and unexposed patients. And we had our wonderful team here at BC Cancer create a wonderful graphical abstract of our paper. And yeah, I'll just quickly highlight that these were our samples. They primarily accrued through our institution here at uh, the Vancouver General Hospital. So this is just the methodology visually presented. Um, Here we can see that the way that we've broken it down is into small, medium, and large p53 signatures. And you can see our pathologists define small as being 12 to 20 cells, a medium-sized lesion between 28 and 80 cells, and a large p53 signature as greater than 80 cells. And then this is just the final results that we that I mentioned ahead of time. So yeah, that is it. Just for one to provide a brief overview about the paper, but yeah.
Yeah, maybe I could just provide a little bit of a backdrop here, because this is a study, and you see from the authorship, like Ram Logan was the third graduate student to work on it. It proved to be rather difficult to kind of gather all of these cases, and the analysis also took a bit of time. But the purpose was to address what we view as a big issue in gynecologic oncology care, and that is that combined oral contraceptive pills have had a massive protective effect in terms of preventing ovarian cancer, with 5 years use being associated with 50% reduction in risk. You could argue that since their introduction, perhaps they've saved more lives than medical interventions totaled, but we have no understanding how this happened. And women are switching away from using combined oral contraceptive pills towards using IUDs, which looks like will not have the same effect, although that's still up in the air. And so we were wondering whether the suppression of occurrence of the earliest precursor lesions could be used as a surrogate endpoint for looking at the protective effect of birth control pills. And that obviously our result would be a negative. But it had this, as Ram Logan pointed out, this interesting secondary finding that suggests that perhaps birth control pills through processes we don't understand, maybe exposure to follicular fluid, maybe direct effect on fallopian tube epithelium, they could suppress the progression of these lesions. And so it raises questions as well as answering perhaps a small question. But that's the backdrop of why we did this. And some of the questions seem to be kind of alluding to the why.
Yeah. Well, thank you both for the presentation, and thank you, David, for adding that additional information. And of course, obviously, a very, very interesting principle. I was wondering if before we start with the questions, if you could provide our audience, for those who may not be familiar with what's a P53 signature, what does that mean?
Ram Logan, would you like to
yeah,
define
I
it?
can go ahead. So P53 signature is one of the earliest lesions of a high-grade serous carcinoma, but there's actually interesting evidence out there that suggests that not all of these P53 signatures will go on to form a high-grade serous carcinoma. So so it's basically a section a group of about 12 plus cells that have a TP53 mutation. And this can be identified, like I mentioned in the figure, by immunohistochemical staining. So within the fallopian tube. Usually, there isn't much TP53 staining. However, when there's a mutant cell, you can find that you'll get a patterning such as this, where there's like a section of P53 positive stains. So yeah, these represent some of the earliest lesions of the high-grade serous carcinoma pathway.
Okay, great. So
Yeah,
we're gonna go.
maybe those are like CIN1 or something.
Okay, perfect. Excellent. Uh, I appreciate that description, David. Now it completely explains the P53 signature. So we're gonna go to some of our fellows and our questions, and I see we already have some questions in the chat. So we'll start with Christian Brown.
Yeah, thank you very much for conducting this very innovative study and for this clear presentation of the results. So as you already mentioned, you categorize these P53 signatures into small, medium, and large based on the number of cells. So my question is, what was the classification primarily driven by clinical consideration, or was the reasoning behind, or what was the reasoning behind choosing these specific size categories?
Yes. We actually went back and forth with our gynecological pathologist, led by Dr. Blake Jilks here at VGH. And based on their professional opinion, they basically looked at the slides, and they basically mentioned that a tertile split, so splitting it into the three categories, would have been able to be the best approach to tease apart the distribution of these P53 signature sizes, while still operating somewhat within like a restricted sample size. So our cohort was about 250 patients, which is relatively small for this kind of study, but we found we had enough evidence to show what we showed. So our pathologists here, yeah, they deemed that as the best method of assessing these P53 signatures. But I'd also like to mention that while this tertile split was being developed, all our gynecological pathologists were blinded to the results. So, and also to the exposure status of each patient and their respective signatures. So this was based on the interpretation of multiple pathologists. So they came to the conclusion that the tertile split would have been the best approach.
Excellent. Thank you so much, Ryan Logan. And our next question comes from Elise Yates, right here in Houston, Texas. Elise?
Hey, thank you guys so much for your presentation today. I just had a quick question. I was wondering, what was the average duration of OCP use by patients in the cohort? And do you think differences in the duration influences prevalence of P53 signatures?
So, I mean, so we don't have, we defined OCP use as 5 years or more. And so we don't have, minimal use data. We also, our sample size really isn't large enough for that kind of split. But I mean, the epidemiologic studies do show a duration effect in terms of ovarian cancer risk. And so however that is happening, we would expect to see some sort of dose response. Our data suggest it may not be in the number of P53 signature lesions. It may be more in the what happens next. But our study isn't a huge study. And another study, which is perhaps designed prospectively, which would be very expensive and difficult to do, could come up with different results.
And David, as a follow-up to that, there's a question from the audience by Payam Kashi in Baltimore. And he's asking, did you control for factors such as occasional hormone replacement therapy for like irregular bleeding?
I think the answer to that is no. We tried to sort of age match the two groups as much as possible. And so we would think that that would be, we would hope the distribution of those features would be even. I don't know, Ram Logan, if you can provide any more clarity.
Yeah, I think what David mentioned was like what we would have done. I think in terms of yeah, like I would say like the study size here was limited in terms of what we could do. Yeah, that's what I would say. Yeah.
All right, very well. So the next question is specifically addressing study populations. So Matteo Marchetti from the University of Padua.
Hi, thank you for the clear presentation. So you state that the study population should approximately represent the general population with a standard risk of developing ovarian cancer. However, in the results section, you find 20 patients in one group and 57 in the other with p53 mutant lesions, which is extremely high. So what do you think the risk rate of developing ovarian cancer is in the presence of p53 signature? And do you think it'd be interesting at this point to specifically study the risk of developing ovarian cancer in patients with a large size p53 lesion only? Thank you.
Yeah, I know it's obviously, these are sort of questions which these data naturally would lead one towards. So yes, would be very interested in that. But so these are individuals who did not have surgeries for BRCA mutations or family histories. And so we would consider them to be an average risk with the sort of just over 1 in 100 chance of lifetime risk of getting one of these cancers. So the P53 signature lesion incidence in the cohort is on the high end of what has been reported in general population cohorts. But I think it depends a bit on to how thoroughly people look. And outside of the CFIM protocol, which wasn't used in these cases because they weren't high risk, ovarian fallopian tubes aren't usually exhaustively analyzed in the general population. So we do admit we are on the higher end on what's been recorded, and there may be something funny about the water in BC we don't understand. I doubt it though. It could be just chance, or it could be that we looked a little harder.
David, there's a question from another interesting question from the audience, and the question is, with the controls being patients operated for benign GYN procedures, could the P53 signatures be due to an inflammatory process? How could we differentiate between inflammation versus like a pre-neoplastic process?
Well, inflammation in itself is pre-neoplastic in a way. We are going to be doing a much more, what we hope is a more interesting study, unfunded and just like a sparkle in our eye at the moment, where this study was the first time where we'd actually managed to get PharmaNet and that kind of drug usage data from a group called Pop Data BC, and then in an anonymized, then without revealing what group patients belong to, pass their names back into the pathology department, pull their cases, do an analysis, and then flow the data back for reconnection to the drug use data. So we now know we can do it. And the next study, which will be a much larger study, where we're going to be doing a lot of spatial genomics to look to see if we can see qualitative in terms of cell type distribution of fallopian tube epithelial cells and inflammatory cells, and qualitative changes, qualitative and quantitative changes in looking at these different exposures, and to have a much sort of deeper look to see what's going on. And it could be a story of information.
And as a follow-up to that question, Albert Jacob also is asking, was there any stratification based on the benign GYN procedures for which the tubes were removed?
No, there wasn't. I don't think there was a massive bias. It included things like fibroids, sterilization, a bunch of different reasons, but we didn't stratify because it's a pretty small study to be slicing and dicing for secondary analysis.
So lots of good questions for a larger study. So next we're going to go to Germany, University Hospital Heidelberg, Kira Fischer.
Yes, thank you for the opportunity and congratulations on the publication. You stated in the article that you did not have any information on the specific timeline, so when the patient stopped taking the OCP and when the samples were gathered. And there was also, as far as I know, not any information on other hormonal influence like the obstetrical history or hormonal therapy. I was wondering how you think things like this might influence the result of the study, so like a time gap between the end of the OCP use and the surgery and other hormonal influences.
The protection of 5 years use or more of combined oral contraceptive pills is lifelong. And so we would think that whatever they're doing or preventing from happening would also be lifelong. But we don't have the specific details on that. We probably could get it, but then again, I think we would be slicing and dicing a cohort which is too small to principally slice and dice it like that. And control pills, pregnancies, I mean, obviously it's not really a modifiable risk factor because you don't tell people to have babies to prevent ovarian cancer, but that's probably one of the longest known protective things which can happen in a woman's life. And we would think that that would probably have an effect, and maybe in the same way, we don't know. In our study, which we're proposing to do, we are also going to include postpartum fallopian tubes because we thought that would be interesting because a lot of women in BC get salpingectomies at the time of cesarean section at this point.
So, and very interesting point from Payam again. Very good questions today, by the way. And he was asking, would be very interesting to examine the impact of OCP use in BRCA1 and 2 patients who would like to delay their risk reducing bilateral salpingectomy versus bilateral salpingo-oophorectomy surgery. What are your thoughts, David, on that?
Even if it reduced the risk by half, that might not be suppression enough in a woman who's got a 30 to 40% lifetime risk. So it does. I think it's been shown to have an effect, but by the OCAC and SIMBA consortia and other groups. But I'm not sure if the effect would be enough to make that recommendation. I mean, I think as a community, the time salpingectomy followed by oophorectomy to prevent premature menopause may be enough of a plateful of change to absorb and study and figure out if it's safe. But this could be that may be just a little too much. I mean, obviously, if somebody absolutely wanted to resist surgeries, and then they should do everything they can possibly do to reduce their risk, and taking birth control pills would seem like a good idea.
Yeah. So Clara Santilla from Argentina, who is now at Houston Methodist. I think Payam might have already stolen your question or somewhat related, but please go ahead.
Okay, thank you for your presentation and congratulations for your work. I think that my question is the same as that was done. My question is, do you think that the use of oral contraceptive pills during intergenetic period must be an indication for young BRCA positive patients who wish to preserve fertility until they complete their desired parity to reduce the risk of ovarian cancer?
So we debated a bit by what you meant by the term intergenetic. We know that you didn't mean introns, or it wasn't a genomic thing. Are you talking about the time between pregnancies, we presumed?
Yes.
Okay, so again, I think this, the effects, if you half a risk, which is very high, it's a good thing to do, but it's not the solution you probably need. But certainly you'd want to do anything you can do to reduce the risk with the knowledge, but we don't have effective screening. So yes, it makes sense. You certainly wouldn't want to do anything which would make getting the second pregnancy happen more difficult, because that could then delay the timing of a salpingectomy even more.
And now, David, another question is, and perhaps you briefly addressed it before, but I was wondering, does it matter the type of oral contraceptives that are used to see this impact?
We believe that progesterone is really important. So it had to be combined oral contraceptive pills. This study is not powered to look at different doses. There's no evidence to suggest that the newer formulations do not have the same protective effect. With the modern IUDs, though, the hormonal exposure will be local within the uterus and is unlikely to have the systemic effect needed. And from what I've seen, women with those IUDs still ovulate, and therefore the follicular fluid exposure would still occur.
Excellent. So now we'll go to Manel Montesinos in Valencia.
Hi, congratulations for the publication. I want to ask, does the predominance of p53 lesions in the femoral region among both OCP users and non-users indicate that OCP influence lesion characteristics rather than their anatomical distribution? And what does this reveal about the pathogenesis of high-grade serous ovarian cancer?
I don't think this study tells us much about the cancer itself. In fact, I don't think I could say there's anything we've learned about high-grade serous cancer itself from this. So these fallopian tubes, they would have been looked at with a sort of modified CFIM proposal. I don't know, like maybe a couple of you may be old enough to remember that when pathologists used to get fallopian tubes, they just take 2 sections through the middle just to show that the fallopian tube was disrupted, and the rest would be kind of discarded. And now people try to squeeze as much of the fimbria as they can into a couple of tissue blocks, and that's it in the low risk scenario. In the high risk scenario, we, like others, use a CFIM protocol. And so that's where most of the surface epithelium is. But this study did not include a principled mapping of fallopian tubes.
Excellent. So there's a follow-up question from Albert in the audience, and I believe Albert will want to ask. Proceed.
Hi, and it was a very interesting paper. So I just wanted to ask, as a follow-up to differentiating inflammatory and pre-neoplastic processes. So based on our experience in pap smears, we can differentiate inflammatory processes and neoplastic processes based on stuff like nuclear morphology and like the hyperchromasia and like the degree of clumping of the chromatin. So I was interested in knowing whether looking at those sort of stuff, since we're taking a tissue block here and we're not taking a cytology specimen, would it be feasible to look into those kind of features over here?
Yes, so p53 signature lesions on their whole. Now, we haven't done an in-depth morphologic assessment of the nuclei, but on the whole, the nuclei look pretty darn normal, and they are invisible unless you use a p53 stain. Whereas a stick shows the nuclear polymorphism, the features you would expect to see in an aneuploid nucleus. So it could be with some kind of higher level analysis, people be able to see a difference. It's not something which a human can see at this point with an H&E slide. These are very, very early lesions. And since their incidence is way higher than the incidence of high-grade serous ovarian cancer, we must assume that the majority of them just disappear over time or don't go anywhere. So looking for mutations is one way people try to establish in the past whether something is neoplastic or not. But the kind of robust and sort of very broad literature on the acquisition of somatic mutations, which are clonal, in normal tissues as we age, has really kind of thrown that one into doubt. So, for instance, in the uterus, KRAS mutations are more common in normal uteri in older women than they are in the cancers that come from that organ, which is kind of shocking. So that's a way people used to sort of try to establish whether something was neoplastic or inflammatory. I mean, this is why one of the reasons why we want to have this sort of spatial analysis and to start seeing, can we see changes in inflammation?
So now we'll go from Vancouver to Toronto. Stephanie Gill.
Hi, thank you so much for your presentation. And it's exciting to see some great research out of Canada. My questions have like slightly been touched on, I think, but I'll still go through them with you. So based on your study and what we know from the literature, do you think the results would be similar for populations with increased risk of ovarian cancer?
That's a very good question. I mean, Ram Logan, would you like to try to address that?
Yeah, of course, comes from Canada.
I've been speaking way too much here, and I plan not to, and then this always happens. Ram,
Yeah.
if you'd like Ram Logan, take a shot at it.
So, well, actually, something similar has been attempted in the past. So like the OV25 randomized phase 2, it was a double-blind placebo-controlled trial looking at aspirin and its use in the prevention of ovarian cancer for women with BRCA mutations. So that was called the Sticks and Stones trial. That was attempted a couple years ago. And that trial actually failed because of accrual rates. Basically, there weren't enough patients who were taking aspirin in that sense, and there's also a contamination in the sense that some of the patients who were part of the control group also wanted to take aspirin for the prevention of ovarian cancer. So what I would say is that it's actually quite difficult, like David mentioned, to address this question. It's a really good question, but it's very hard to do just because of those other factors that might influence the study.
We actually had a clinical trial a few years ago with it was with Malcolm Pike, who's a sort of epidemiologist, and some folk at Memorial Sloan Kettering in Michigan, for women who were getting a risk-reducing salpingectomy or salpingo ovarectomy in the context of BRCA mutations, and to randomize them to birth control pills or not for a month or two before they had their procedures. And we had zero accrual. It turned to be logistically impossible. So others may be able to do this. It would still be a very valid thing to look at, but we failed miserably.
There you go. So Stephanie, you can take another crack at those studies. But definitely you probably would need to have a better name than Sticks and Stones trial.
That was a meats one. That was the one on aspirin. And
yeah.
It doesn't seem like if you invite someone into a room called Sticks and Stones, it's some people may not want to enter.
Exactly. So Julia from University of Wisconsin-Madison.
Thank you guys for sharing your results and discussing them with us today. My question is similar to the first part of Stephanie's question, which is thinking about your results in the context of other literature. You guys cited another paper that looked at a BRCA mutated population and showed decreased rates of P53 precursor lesions in patients who had oral contraceptive exposure in that population. I was wondering if you could talk to us about your thoughts on why oral contraceptive exposure might have a different impact based on, the rates in that study versus the size of lesions in your study.
Ram Logan, do you want to have a...
Yeah, so this is actually a very interesting question, and primarily it could be due to just the biological differences of the fallopian tube epithelium between the BRCA mutation carriers and the general population, but it can also actually be due to the timing of fallopian tube removal. So in BRCA mutation carriers, for just preventative methods that are used, their fallopian tubes would likely be removed at an earlier age compared to the general populations. So quite possibly there is a difference in terms of the fallopian tube biology in those individuals who have had their fallopian tubes removed early compared to those who had it removed at 50 years or later. There is actually a paper that came out not too long ago, and they used functional mouse models to show that OCPs, so the progestins, specifically progestins, can actually target TP53 mutant cells and target it for necroptosis, which is a form of apoptosis. So we're thinking that quite possibly the differences in terms of like the biology between the BRCA mutation carriers and between the general population carriers and the use of OCP in these two in these two populations could be attributed to basically the use of OCPs in terms of reducing the lesion size. So I suspect that it's like the biology part may be the difference between the two, but we'd have to like conduct functional studies. So perhaps like look at mouse models and try to recapitulate a P53 signature, which is extremely difficult to do to answer any questions related to the biology of fallopian tube epithelium and BRCA mutation carriers in the general population. But like David mentioned earlier, we're going to try to take a crack at it, and we're going to try to first look at spatial transcriptomics, looking at OCP users and just the biology of the fallopian tube epithelium from a spatial transcriptomics perspective, and see what differences we can see.
Excellent. Thank you, Ram Logan. And we'll close out the questions from the fellows with Thomas Bartel from the Medical University of Vienna in Austria.
Yeah, thank you for sharing your data. Like for me, the theory of P53 signatures as early precursors of high-grade ovarian cancers appears compelling, but to my knowledge, there's currently no available data establishing a clear association between incidental findings of P53 signatures and high-grade ovarian cancer in average risk population. So how would you plan to further investigate the potential clinical relevance of the present findings?
Well, you know, among the larger lesions, I think there was 1 or 2 sticks which are associated. And some of the kind of phylogeny studies have shown associations with P53 signature lesions and concurrent cancers. So there does seem to be a connection with some P53 signature lesions can progress. But the actual steps in that progression and what has to happen and why some progress and others don't, is not understood. There are gaps.
So thank you so much to all the fellows, obviously, for submitting your questions, for participating. I want to thank David and Ram Logan for, again, sharing your thoughts and your discussions on this manuscript with us. I think we gather from this journal club that there's certainly many opportunities for future research and further ongoing exploration of this theory. So I want to thank you again, both of you. I want to thank all the fellows once again. Thank everybody who joined us for the Journal Club. I want to invite everybody to the March Journal Club that is going to be discussing our special issue, the 2025 special issue on management of rare gynecologic cancers. Thank you so much, and have a great rest of your week.
Thank you. Bye.
Thank you.